So good morning, friends. I'll be discussing something about epithelial thickness profile and why it is important in refractive surgery. So let's know some facts about epithelium. So other than epithelium being a barrier to the external environment, along with the tear film, it also represents an optical interface and plays a critical role in the refractive power of the eye. Small changes in corneal epithelial thickness can cause significant refractive changes, and the refractive power of the epithelium itself ranges from 0.55 to 1.85 at a central 2 mm diameter zone. So, epithelium has power. This is something we always should remember. So, in normal corneas, the average central epithelial thickness is around 54 microns with a standard deviation of 4 to 5 microns. And Reinstein et al. Have demonstrated a non-uniform pattern of epithelial distribution wherein the superior and temporal corneas are thinner compared to inferior and nasal quadrants. So, as one word of caution, the epithelium is not a homogeneous depth over Bowman's layer. So it's not a homogeneous layer. What epithelium tries to do is that it compensates for the underlying stromal irregularities, wherein it becomes thick over the valleys and thin over the hills wherever the stroma protrudes. So basically, it attempts to minimize the abrupt changes in the stromal thickness. So the anterior cornea may appear smoother on topography, as Dr. Sheetal also showed in some of her examples. So it is important to study the epithelium separately. So assessment based only on topography with no knowledge of epithelium may sometimes be misleading. So essentially we have ASOCT and ARC scan, which is very high frequency ultrasound, two main modalities to measure epithelium. So ASOCT is based on the spectral domain OCT, wherein 24 radial scan lines with a scan depth of 2 millimeters are used to generate a color coded thickness map of the cornea, whereas the ARC scan utilizes a 50 to 100 megahertz ultrasound system. So OCT is a non-invasive and non-contact method, whereas the ARC scan is an immersion-based method that needs special medium and topical anesthetics. So OCT is less operator dependent, and ARC scan has high operator dependency. Repeatability and accuracy is thought to be better for OCT, whereas it can sometimes suffer due to corneal compression or decentered positioning of the probe with the ARC scan. And tear film is included in the measurement when OCT measures epithelial thickness, and it's not included with the ARC scan. So coming to differences between different OCT machines for epithelial thickness measurements. So right now we have the OptoView, the Cirrus 5000 and MS39 from CSO Italia. So for the OptoView and Cirrus, you need a cornea external lens, whereas this is not required for MS39. The resolution in tissue is best for MS39, this 3.8 microns in tissue. For OptoView, it is 9.9, and for Cirrus 5000, it is 12.5. The area measured is again widest for the MS39, 16 millimeters versus 6 millimeters in OptoView and 9 millimeters with the Cirrus 5000. Now coming to clinical applications of epithelial thickness profile study. Basically, the most important application I would say is screening for ectasia risk in refractive surgery candidates. So as we all know, corneal thinning is a hallmark of ectatic corneal diseases, and if you look at the histology, basically it looks like in an area in ectasia, a localized zone of epithelial thinning over the steep area surrounded by an annulus of thickened epithelium, which is classically referred to as epithelial donut pattern. So here we have a case of keratoconus, 26-year-old female, and you can see that this is a frank case of keratoconus, and there's this bulge here on the anterior curvature map, and correspondingly, if you look at the epithelial map, which is the central one, the lower figure. So here you can see that the blue zone is denoted by a very thin epithelium, and around this thin epithelium you have a donut shaped pattern of a thickened epithelium. Now, this is a classical donut pattern which you see in keratoconus cases. Now, not that every time you will have such clear cut cases. So many times we come across suspect topography, wherein you can just have few features of a suspicious cornea, but it may not be a keratoconus. So these are the cases where epithelial thickness will actually help you in making the picture more clear. So such as in this case here, if you see, there's some amount of inferior superior asymmetry and posterior elevation observed on pentacam. When you repeat the scan with MS39 for this patient, you can also see on the epithelial map there, the right upper image. So there is there is a epithelial thinning. So there's a thin area which is also surrounded by a thickened area. So it's an early donut pattern which is starting. And what is most important here in MS39 is that it also gives you stromal elevation map. So you must also look at the stromal elevation map, wherein you can see that corresponding to the area of ectasia, there is also about 9 to 10 microns of elevation of the stroma. So in this way, epithelial thickness can also help us to enhance the specificity and avoid false positive cases, because many times we see that at pentacam there's a overdiagnosis of keratoconus. So these cases can actually be ruled out by using by studying epithelial thickness profile. Also planning refractive surgery procedures such as transepithelial photo refractive keratectomy, which is the trans PRK, and PTK procedures. So you must keep into account the vertical variability in mapping of different zones, and this is also important to maintain accurate refractive results and avoid creating unintended corneal abrasions. So epithelial thickness is also important to study refractive regression after refractive surgery. So as expected, if you treat higher amounts of refractive errors, you can expect more epithelial changes, and this can help us to differentiate the various reasons why somebody can have a power after surgery. So we did a study basically to see epithelial changes post smile, and we found that in low myopic group there was a 6.83% of epithelial thickness increase in the center. In the moderate myopia it was 9.27%, and in high myopia it was as high as 12.7%. So this also can actually help you decide your nomogram. So if you see that at 3 months or 6 months you're having a lot of epithelial changes, so you can also look at revising your nomogram. So this also helps us to differentiate between regression and undercorrection seen in the postoperative period. So again, another very important indication is to differentiate between early ectasia versus regression. So because this is so important, if you misdiagnose a ectasia and treat it like regression and treat the patient with a laser second time, it's going to make the condition worse. So like these are two cases. You can see both cases are post smile. The first one is post smile. 6 months later patient develops slight power -1 with 0.75, improving to 6/6. And on the right side, this patient is smile 3 years prior smile was done, and patient has a similar type of power. But if you look at the scans of both the eyes, the epithelial scans, you can see that the pattern is completely different. In the first map there is a central thickening, and in the right map there is a central thinning, and this is being surrounded by a early donut pattern. So on the left side what you're seeing is a thickened epithelium due to regression, and on the right side is basically early ectasia. So it can also help you differentiate between myopic and hyperopic ablations. So many times we come across LASIK patients who have come for cataract surgery opinion, and they do not have any history or any reports available. So when you do a topography, then you will actually you sometimes are not able to make out whether it's a myopic ablation or hyperopic ablation, because if it was a low refractive error, then the epithelial changes would have masked the picture to some extent. But when you do epithelial mapping of these cases, it makes the picture more clear. It can also be used to plan enhancements, especially after smile. If you want to do a thin flap LASIK for smile enhancement, it is an indispensable tool, because you want to know the epithelial thickness before performing the correction, and this is basically to avoid creating a too superficial flap that may enter into the previous interface. So to conclude, knowledge of epithelial thickness profile is especially beneficial in close call judgments, clinical judgments. It's a newer modality that newer modalities combining epithelial profile and stromal elevation maps like MS39, as I said, enable a more confident decision making by ruling out false positive cases of suspect keratoconus before refractive surgery. So in this way, it is a quite a indispensable tool, and nowadays we are seeing epithelial profile for all our patients before planning the type of procedure even for them, and also in cases with contact lens users. So in these cases also, epithelium can sometimes give a very different kind of picture, so you can ask them to stop the contact lenses and then repeat the epithelial scanning and then take a proper decision. Thank you so much for your attention.